TK, for those of you who knew him or knew of him, was one of the pioneers in wound healing research dealing with the role of oxygen in getting wounds to heal. And so this year's TK Hunt lecture honors that legacy in a major way. It's the 12th lecture that we have given under this auspices of this endowed lecture. And it's my very distinct pleasure this year in particular to bring somebody who elucidated the molecular importance of oxygen in our cells. He won the 2019 Nobel Prize in Physiology and Medicine for this work. And it was basically, in many respects, typifies the cross-disciplinary aspect of it. Dr. Kaelin shared the 2019 prize with Greg Semenza and Peter Radcliffe. And Peter Radcliffe and Greg were sort of mainstream oxygen people. They were looking at the role of erythropoietin, which many of you know is very important in that. And Greg in particular figured out HIF1 alpha, which many of us quote in our papers as being a key determinant in figuring out if wounds have enough stimulation to heal. But it was Bill that sort of unlocked the puzzle. And he did it in a very unusual way. He'll give us a talk about this because his role is, the talk is on the role of oxygen in how cells sense things. But he brought into play the role of von Hippel Lindau gene. And that's kind of odd if you think about it. But it's how the genetics of it change in response to exposure to oxygen. And so Dr. Kaelin did this work in the early 2000s. It takes the Nobel Committee a few years to catch on to the importance of this work. But it has changed all of our lives in terms of understanding in the cancer world, in the wound healing world, and in many different fields. Now, he's not resting on his laurels, literally or figuratively. He then went on to elucidate mechanisms for how mutations in these genes can be harnessed to both help therapies, and in particular, how to help cure kidney cancers through manipulations of the VEGF sensing and things like that. And so I'm not going to spend a lot of time elaborating. I think in your handout there was a biography on Dr. Kaelin. But he's a Howard Hughes investigator. He's been that since 1998. He's been a full professor at Harvard Medical School since 2002, and he holds the title of the Sidney Farber Professor of Medicine at the Farber. So that's I think no higher honor could be accorded to bear that title. He's going to give us a talk today on oxygen sensing in cells. And so the Wound Healing Foundation is very honored to participate in your DLS meeting this year. And without further ado, I would like to introduce Dr. William Kaelin, Jr.
Well, thank you, Paul, for that very nice introduction. And thank you for setting it up that this is meant to be cross-disciplinary, although I will use the word diabetes once or twice, I promise, if you pay attention. So here's my disclosure slide. And here are the people who have worked on Hippel Lindau disease in my laboratory over the years. And here's a partial list of our wonderful and very generous collaborators who have helped us. So I was sort of a late bloomer in school. I actually was a better college student than I was in high school, but back in those days you could be a late bloomer and still get into a good school, and sadly that's less true today. I went to Duke as a pre-med, and I was actually doing pretty well academically, but someone said if you want to apply to medical school, it would look really good if you worked in a laboratory to show people you have an interest in research. So I met with a chemistry professor who said, I've had a series of undergraduates work in my lab. In fact, I've had 7 undergraduates work in my lab, and they've all gotten into medical school. So I went skipping out of his office thinking I've gotten the golden ticket to medical school. Now, if I was a little smarter, a little bit wiser, I might have asked, well, why couldn't these 7 undergraduates bring this project to completion? And I became the 8th undergraduate who could not bring this project to completion. And I can tell you with the benefit of hindsight and lots of psychotherapy, the project was unimportant, uninteresting, and undoable, which is a perfect triad for extinguishing a young scientific career. And to reward me for the fact that I had floundered in his laboratory for 18 months, not knowing what I was supposed to be doing, he gave me a C-, which of course for a pre-med is like having a wooden stake driven through your heart. And then to make sure his point wasn't missed, he wrote in the margin of my transcript, Mr. Kaelin appears to be a bright young man whose future lies outside the laboratory, which is like a surgeon telling you you have the hands of a hematologist. So this was not a very good start, and then this had the expected chilling effect on most of my medical school applications, including the one where I'm currently employed. But fortunately, Duke miraculously took a chance on me, so here I am as an entering medical student at Duke University. You can tell it's the 70s from the haircut. Now, one thing that saved me at Duke was they compressed the first 2 years of classroom learning into the first year. You then went on to the wards your second year, which sort of brought medicine to life. And then in your third year, you were encouraged to do research. So with some trepidation, I worked in a laboratory that studied tumor blood flow. Here I am in my first poster. It was a fairly lonely experience, I might add. But here's my first paper with my mentor, Randy Jurtle, and I'll point out that the topic here has to do with tumor blood flow. So I was beginning to learn something about angiogenesis, and that served me very well as we go through the story. Now, this was not enough to convince me that I was going to be a researcher. I was dead set on being a clinical doctor, so here I am at the first day of internship at Johns Hopkins in 1983. There I am in the back row with a nice starched white coat. And I was so sure I was going to be a clinical doctor, I stayed an extra year at Johns Hopkins. It was effectively one of the 4 chief residents. They happen to call them assistant chiefs of service, but effectively it's the chief resident. Now, the person who changed my life was David Livingston. So I then went on to the Dana-Farber to do clinical training in oncology. But again, one path to being board certified in oncology was to work in a laboratory for 2 years. And I thought, well, I don't think I'm going to do research, but I can see that research has the potential to change the world. So maybe I'll at least get to see how a high-functioning laboratory operates. And it was really David who opened my eyes to the possibility I could be a scientist. And he's really the person who really crafted me into a scientist. And so much of becoming a scientist was taught by apprenticeship. There's a reason why many great scientists have trained with great scientists, and there were none better, in my opinion, than David Livingston. So if you were paying really close attention, you might have noticed this distinguished gentleman was standing in the front row of my Johns Hopkins composite picture, because Victor McCusick was my chairman when I was an intern. And of course, Victor was one of the fathers of modern clinical genetics, and also was a bit of a medical historian. So I like to tell this story as a medical detective story, and I'd like to start the story with some clinical observations. So in hindsight, the first family that we would now say had von Hippel Lindau disease was in this paper by the English geneticist Treacher Collins, published in 1894. And Treacher Collins described siblings who had unusual vascular lesions of the eye, which we would now refer to as retinal hemangioblastomas. Now, ironically, Treacher Collins' paper was largely overlooked, however, because this was the great descriptive era in medicine. And if you could read only one literature during the great descriptive era in medicine, you read the German literature. In fact, I was probably one of the last high school students in America back in the 70s who was told if you want to go into medical school, you should study German. So I actually studied German for 3 years. So Eugen von Hippel described a very similar family, but he had the benefit that he published in a German language journal, as did Arvid Lindau, a Swedish pathologist, neuropathologist. Now, Lindau was really one of the heroes of this story for many reasons, because Lindau appreciated that these retinal lesions were simply the tip of the iceberg and were often associated with other lesions. So in the upper left here, I'm showing you the fundoscopic view of a patient with von Hippel Lindau disease. Here's the optic nerve, of course, and here's a retinal hemangioblastoma. It's easier to appreciate these lesions, especially when they're small, if you inject the patient with a fluorescein dye. You can see this patient has multiple small retinal hemangioblastomas. But importantly, these patients also develop hemangioblastomas of the cerebellum and spinal cord. So here's a sagittal MRI of a patient with VHL disease. This patient has a large cystic hemangioblastoma with the solid component shown here. And these patients also can develop numerous preneoplastic renal cysts. And sometimes these renal cysts harbor clear cell renal cell carcinomas, which is the most common form of kidney cancer. So here, the urologist has unroofed a renal cyst and has discovered a clear cell renal cell carcinoma arising from the cells, the epithelial cells lining the cyst cavity. So this came to be known as von Hippel Lindau disease, with apologies to Treacher Collins. It affects about 1 in 35,000 people. It's caused by loss of function and mutations of the VHL tumor suppressor gene, chromosome 3p25. And now I've introduced to you some of the tumors that these patients develop. They also develop neural crest tumors, including pheochromocytomas. So here's some families that have been followed at the NCI over the years. You can see that actually clinically this looks like an autosomal dominant disorder. Of course, the affected individuals here are the filled circles and squares, and we've already talked about the cardinal tumor seen in von Hippel Lindau disease. Now, fortunately for me, when I started my own laboratory in 1992, shortly thereafter, this paper appeared, which was the cloning or isolation of the gene. That one mutated in the germline, gives rise to von Hippel Lindau disease. So just to make sure we're all on the same page, individuals with von Hippel Lindau disease have inherited a defective copy of the VHL gene from mom or dad. In this schematic, it's the maternal allele. But initially, they're okay because they have the remaining wild type allele. But unfortunately, if you're born with this configuration, you have a 90% chance that a susceptible cell in your body, such as in the brain or the eye or the kidney, is going to spontaneously lose or mutate or silence the remaining copy, and that's the cell that will go on to cause problems later on. And as you would predict from the knowledge that germline VHL mutations predisposed to, for example, clear cell renal cell carcinoma, which again is by far the most common form of kidney cancer, you now see a biallelic mutation or inactivation of the VHL gene, but here both mutations or hits, if you will, have occurred somatically, in contrast to von Hippel Lindau disease, where the first hit has occurred in the germline. Now, I knew from my clinical training that the tumors seen in von Hippel Lindau disease are highly angiogenic. I've already shown you this retinal medulloblastoma, but kidney cancers are also notoriously angiogenic. In fact, in the pre-CAT scanner, or the diagnostic procedure of choice in patients suspected of having a kidney cancer was to do a renal angiogram to look for the appearance of new blood vessels, which was sort of a smoking gun that that kidney harbored a kidney cancer. I also knew from my clinical training that these tumors sometimes cause patients to make too many red blood cells, to develop secondary erythrocytosis, paraneoplastic erythrocytosis. In fact, we all know that chief residents love rare eponymous syndromes because if a trainee ever challenges your authority on rounds, you simply pelt them with questions about rare diseases like von Hippel Lindau disease, and once again, you're alpha and rounds can proceed. But chief residents also love differential diagnoses, and the longer the better, because as long as you know one more cause for any symptom or sign than anyone else, and once again, you're alpha. So I memorized lists like this. These are the causes of excess red blood cell production. Some of these are clearly adaptive, such as living at high altitude or certain chronic heart and lung conditions, but some of these are clearly maladaptive, including some tumors that cause excess red blood cell production. And it always struck me as odd that the three tumors seen in von Hippel Lindau disease make this list, especially given how otherwise rare hemangioblastomas and pheochromocytomas are. So taken together, I knew from my clinical training that the VHL-associated tumors are highly angiogenic, and that's because they overproduce vascular endothelial growth factor, and I just told you they occasionally stimulate red blood cell production, and that's because they sometimes ectopically produce erythropoietin, and what VEGF and EPO have in common is that they're normally induced when cells or tissues are not getting enough oxygen. So that was the clue that by studying the VHL gene and the protein it encodes, we might learn something about kidney cancers, but we might also learn something about angiogenesis, and we might learn something about oxygen sensing along the way. So we knew from the work of multiple laboratories, including the laboratories of my fellow laureates, Greg Semenza and Peter Radcliffe, that many of these so-called hypoxia-inducible genes were under the control of a transcription factor called hypoxia-inducible factor, or HIF, that consists of an unstable alpha subunit that's normally degraded if oxygen is plentiful, hence hypoxia-inducible factor, and a constitutive beta subunit that often goes by the alternative name of ARNT. And to sort of image the system non-invasively, we made a mouse that ubiquitously expresses a luciferase fusion protein where firefly luciferase has been fused to the fragment of HIF1 alpha that's sufficient for oxygen-dependent regulation of HIF stability. So now if you give these animals luciferin and you have a sensitive camera for detecting the photons being emitted from the luciferase, you can see that already, even under 21% oxygen, there's a signal over the kidneys. I'm embarrassed to say that initially surprised me, but it's been known since the 1940s that the kidneys in mammals are hypoxic at rest, so this was actually what I should have expected. But what's very clear is if you now have these animals breathe a lower oxygen mixture, the system gets activated and HIF gets stabilized. So over the course of time, our group and others showed that the VHL protein is part of a so-called ubiquitin ligase that in the presence of oxygen covalently attaches a polyubiquitin tail to HIP alpha, which then targets it for proteasomal degradation. Whereas when oxygen levels are low or the VHL protein is mutated, now HIP alpha can accumulate, dimerize with its partner protein and activate genes such as VEGF. So this was very satisfying because it explained why loss of VHL would lead to deregulation of things like VEGF and EPO, but it still begged the question, how does the VHL protein know, if you will, whether oxygen is or is not available, and hence whether it should or should not target HIP for destruction? And the answer that we arrived at, and Peter Radcliffe arrived at in parallel, is that in the presence of oxygen, one of two conserved prolyl residues, and HIP alpha gets hydroxylated, and this then generates a high affinity VHL binding site. Parenthetically, I increasingly go to meetings where I'm sort of in the back row, kind of watching what's happening, and increasingly, and part of this is my age, I can't really see the slides or what's on the side. There's 7 panels, and there's 10-point font, and then there's all sorts of maps, and and this to me was what a slide was supposed to be, because I hope even the people in the back of the room can see the answer. So I'm railing about, let's bring back simpler slides so we can all educate each other a little bit more effectively. And no one ever got mad at me because I made them feel smart, right? So if you showed the slide and they kind of go, yeah, I get it, that's not such a bad thing. All right, so the enzymes that do the work here of adding the hydroxy group are the prolyl hydroxylases known either as the Kaelin prolyl hydroxylases, or the alternative names are the PhD prolyl hydroxylases. They split molecular oxygen, and they use one of the oxygen atoms to hydroxylate HIF. Parenthetically, they require reduced iron, which explains why iron chelators, when added to cells in culture, will mimic a hypoxic response. And they also require a cofactor from the Krebs cycle, which is either called 2-oxyglutarate, or if you prefer, alpha-ketoglutarate, which gets decarboxylated to succinate. And finally, although not shown here, these enzymes have very low oxygen affinity, so they're very sensitive to changes in oxygen in a physiologically relevant range. This is in stark contrast to the collagen prolyl hydroxylases I know some of you study. The collagen prolyl hydroxylases have extremely high oxygen affinities. You'd have to be virtually anoxic before a collagen prolyl hydroxylase would cease to function. Now, these enzymes are eminently druggable. I don't show structural biology slides unless even I can see the answer. So this is the region of the Kaelin-1, which is the primary HIF prolyl hydroxylase, also called PHD2. This is the region of the enzyme that normally would accommodate that cofactor 2-oxyglutarate. So this is a nice, deep, druggable pocket, and to make the point, the scientists who did this work at Amgen have even inserted a tool compound that inhibits these enzymes. So there are a number of these in late-stage clinical development. I have a conflict of interest related to roxadustat, which is being developed by Fibrogen, but there are others as well. Here's an early study in patients who have anemia related to chronic renal failure, where patients were given orally this prolyl hydroxylase inhibitor, roxadustat, or placebo. You see a nice induction of EPO as you stabilize HIF with this orally available agent. You can bring the patient back in a month and do the same thing, so there's no evidence of tachyphylaxis. As you would hope, this translates into an improvement in hemoglobin levels. Now, it turns out for a variety of reasons, the first one of these to be approved was daprodustat, where I don't have a financial conflict of interest. This has now been approved for the treatment of chronic kidney disease patients who are on dialysis and have anemia, and the second one has now also been approved from Akebia. Now, why do all metazoans have this system that I just described to you? So it turns out that every animal that's been looked at has this system. All metazoans have this system. It's certainly not to cause von Hippel Lindau disease. It's presumably because if you're a multicellular organism and you're hypoxic, you need a mechanism for sensing oxygen and then responding to oxygen to adapt. And so based on sort of teleological arguments, we and others thought, well, if you had a drug such as, again, we'll say roxadustat, that inhibits Kaelin, it would stabilize HIF, and maybe this would confer protection in models of regional ischemia, such as during cerebral infarction or myocardial infarction. So it turns out in mouse models of myocardial infarction, this is certainly true. So here's an experiment where in cell culture, we added a tool compound that stabilizes HIF. Here's induction of HIF by Western blot. I've already showed you that this compound, here's the Western blot. I've introduced this reporter mouse to you earlier, but here we're giving the reporter mouse the HIF stabilizer rather than bona fide hypoxia. You see stabilization of HIF. And now here we're doing experimental myocardial infarctions. So on the y-axis is the amount of heart muscle damage in animals that were given a placebo at the time of the infarct or the HIF stabilizer at the time of the infarct. Now I will readily admit that this works better if you give the drug prior to the infarction, but you can still see some benefits even 2 hours after the infarction. Now we always like to complement our pharmacological experiments with genetic experiments. So here we've made a mouse that has a conditional eglin-1 allele, and again, eglin-1 is the primary HIF prolyl hydroxylase, and we can now inactivate this gene in adult animals because the animals also express a Cre-ER fusion protein that can be activated by tamoxifen. And so now, if we acutely inactivate eglin-1 and again do myocardial infarctions, you see substantial protection when we've inactivated eglin-1. Now, just to stay on mission here, there actually is a literature that argues that if you can stabilize HIF, that might be a good thing for diabetic wound healing. Here's one such paper where they used, again, a pharmacological tool compound that stabilizes HIF and showed improved wound healing. They also delivered locally a virus that encodes a stabilized version of HIF that can't be recognized by the VHL protein. Here's a maybe cleaner experiment where they knocked out the main prolyl hydroxylase that they're using, the PHD2 nomenclature, and they found that if you inactivate the prolyl hydroxylase, you can promote wound healing, especially when you do it in the keratinocytes. So I don't get too excited about new targets until I see 2 or more labs kind of arrive at the same answer. So it turns out there are far more than 2, but I just showed you 2. I also like to see corroborating lines of evidence. I like to see genetics, I like to see pharmacology, et cetera, et cetera. Now, there's a saying, all models are wrong, but some are useful. I suspect there are lots of experts in this room who might be already laughing that these mouse models don't really tell you anything about wound healing in people. Maybe that's true, but I wonder whether this is something that should be pursued by someone. Now, getting back to the role of the VHL gene in kidney cancer, if you look at VHL patients, again, they're effectively, we'll call them VHL heterozygotes. Over decades, they'll develop renal cysts, and when you look at the cells lining these cyst cavities, they're already VHL null. So VHL loss in the kidney causes renal cysts, but it isn't sufficient to cause cancer. You need other mutations involving other loci for those renal cysts to become tumors. So that's that's hereditary kidney cancer. If you now look at sporadic kidney cancers, you see a very similar picture. So here, I apologize for the busy slide. Here, what Charlie Swanton and colleagues have done is they've done spatially distinct biopsies of kidney tumors, including, when possible, metastases. And then they've done deep next-gen sequencing to measure variant allele frequencies, and have used those variant allele frequencies to infer the evolutionary history of that tumor over time. And so almost invariably what they see is the initiating event is complete inactivation of the VHL gene, and then you see these other cooperating genetic events, and I'll point out that some of these occur in a subclonal or branching pattern, in contrast to VHL loss, which we refer to as the truncal or initiating events. Now, we knew that HIF was deregulated in these tumors, but was HIF really the driver in these tumors? So someone had to do the causality experiments rather than simply relying on correlation and plausibility arguments. So years ago, we showed that if you restore the function of the VHL protein in a VHL defective renal carcinoma cell, they lose the ability to form tumors. And then Keiichi Kondo took these cells and introduced into these cells a version of HIF alpha, and in particular HIF2 alpha, that can't be recognized by the VHL protein because the prolyl hydroxylation sites have been converted to alanine, and now these cells regain the ability to form tumors. And in a complementary set of experiments, he took VHL null renal cell lines and eliminated HIF2 alpha using short hairpin RNA technology, although we now do it with CRISPR, and these cells lose the ability to form tumors. And I will tell you, to our surprise, when we did analogous experiments with HIF1 alpha, which is the more famous canonical member of the family, we got the opposite result. So the bad guy, at least in kidney cancer here, is HIF2 and not HIF1. Now, what can we do about this? Well, we knew by the 90s that VEGF was upregulated in various tumors and was probably important for tumor angiogenesis. And so we argued that if VEGF inhibitors, which were being developed at the time, were going to work in any solid tumor, they should work in kidney cancer because of this intimate link between VHL loss, upregulation of HIF, and consequently upregulation of VEGF. In fact, if you look at VEGF levels, which is what we're measuring on the y-axis here, across a variety of tumors, you can see that the 800-pound gorilla is kidney cancer. So what I'm showing here, the green dots, if you can see that they're green dots, are the normal VEGF, the VEGF levels in the normal tissues, and the red dots are the VEGF levels in tumors arising from those tissues. And I think you can see that, yes, this modest elevation of VEGF in most tumors, because most tumors contain regions that are hypoxic, but predictably, in kidney cancer, the VEGF levels go off the roof. And presumably because they've upregulated VEGF early, there's no selection pressure for them to activate alternative or collateral angiogenic pathways. You can pretty much predict these tumors are going to be using VEGF to drive their angiogenesis. So we're now up to, I think, 8 VEGF inhibitors that are approved for the treatment of kidney cancer. That's the good news. The bad news is not every kidney cancer patient will respond to these drugs. And even those that do will eventually progress. So unfortunately, sometimes it takes a number of years. So how can we do better? So based on first principles, you would say, well, rather than targeting any one HIF target gene, you should target HIF itself. And if you believe your own data, you should target HIF2 specifically. But the conventional wisdom for many, many years was that HIF was not druggable because it lacked a natural druggable pocket. It was a DNA binding sequence-specific transcription factor. It didn't belong to the steroid hormone or receptor family where there is such a ligandable pocket. And so people just threw up their hands and said, you'll never be able to target HIF. So for the young people, beware of dogma, because it usually just takes a smart person and a champion to show that dogma is wrong. So here the champions were Rick Bruick and Kevin Gardner, who were then at UT Southwestern. They identified a potentially druggable pocket in the so-called PAS-B domain of HIF2 alpha, which is what I'm showing you here. They did high throughput screens at UT Southwestern and identified chemicals that could bind to this pocket, and in so doing induce an allosteric change in HIF2 alpha such that it could no longer bind to ARNT and hence no longer bind to DNA. Now these chemicals were what my drug hunter friends call publication quality, but not pharmaceutical quality. They had a number of blemishes and warts, but fortunately they out-licensed these chemicals to a biotech company called Peloton Therapeutics that was subsequently acquired by Merck, and I should again declare a financial conflict of interest here. I'm also surprised this made it through the CME police, who were pre-scrubbing my slides, because usually the CME police hate this, so I should blank this out. But here's a tool compound that was developed by Peloton, where they've improved the potency, the specificity, the bioavailability of this compound. And at the time, this was only 1 or 2 atoms removed or different from what was then the lead compound. So our lab and Jim Brugarellis' lab, and Jim was a former postdoc of mine, ran this tool compound through preclinical models of kidney cancer, orthotopic tumor models, soft Dagger assays, et cetera, and we showed that this compound did everything you would hope for. It suppressed HIF2 activity, HIF2 target genes, that suppressed the proliferation of kidney cancers, both ex vivo and in vivo. And not shown was we did a number of controls to really convince ourselves that this was a specific on-target effect. So eventually an approved version of this inhibitor called belzutifan went into clinical trials for patients with advanced kidney cancer who had failed standard of care agents such as 1 or more VEGF inhibitors. They'd often failed so-called immune checkpoint inhibitors. So for those of you who aren't used to looking at this type of data, these are so-called swimmer's plots. So each horizontal bar is a patient on the trial and how long they were on therapy at the time of this analysis. So for orientation, this is 1 year on therapy. The patients with the black arrows were still doing well on therapy at the time of this analysis, and the yellow star patients had a so-called RESIST partial response. This drug eventually went into phase 3, where the results were positive, and recently the FDA approved this drug for the treatment of advanced renal carcinoma for patients who have failed standard of care agents. And again, I declare a financial conflict of interest here. Now, a truism in medical oncology is that most drugs work better in a frontline setting than in very late lines of therapy where you really had a lot of disease progression and you've beaten up the patient with all sorts of noxious drugs. It's just much better if you can get your drug into a more frontline setting. Now here we were aided immeasurably by the fact that the VHL patients are very well organized. In fact, this was literally one of the first websites I ever stumbled upon back when the internet was still a thing, because I couldn't believe that this rare hereditary cancer syndrome would be associated with its own website, but it really is. And that's because these patients figured out a long time ago that the disease is sufficiently rare that they often know more about their disease than their doctors, and the path forward was to share information in real time around the world. So kudos to them. But it also became a great way to find patients with VHL disease who might be available for clinical trials. So we convinced Peloton and then Merck to treat 61 patients with von Hippel Lindau disease who had measurable kidney tumors that had never been treated medically before. These patients develop so many tumors over time that they're often put in careful surveillance programs where they'll get an MRI every 3 or 4 months, and only if the tumors start to enlarge in a suspicious or troubling way will they go back to the OR. So these were patients in surveillance programs who had measurable kidney tumors, but I'll point out they could also have other VHL-associated lesions as well. So now you can see that it looks even better. So once again, this is 1 year on therapy. Most of the patients are doing well. Here's the follow-up data. I presented this recently. You can see patients out doing well 3 or 4 years on therapy, and again, many of them are getting partial responses. If you prefer so-called waterfall plots rather than swimmer's plots, here I'm showing you the shrinkage of the indicator kidney tumor, the indicator lesion, the kidney tumor. So I'm a lumper rather than a splitter, so I would say all the tumors were getting somewhat smaller, but if you like RECIST criteria, I think at this point the RECIST response rate is about 60%. These patients could also, as I mentioned, have other incidental tumors, so some of these patients also had CNS hemangioblastomas. You can see them shrinking. Many of these patients had a particular type of neuroendocrine tumor of the pancreas called PNET. You can see those tumors responded as well. And maybe most strikingly, I mentioned these patients were in surveillance programs. So the gray period here is the 4 years these patients were monitored before going on therapy in green. And every place you see a diamond or a square or a circle, triangle, whatever, the patient's going back to the operating room to have yet another tumor removed from their eye, spine, kidney, whatever. And you can see once they go on the HIF2 inhibitor, the surgeries dramatically decrease. Now, I was a clinician when I was younger, and I know even now we look at clinical data and we sometimes forget that there's a real human being attached to every bar or triangle or dot or whatever it happens to be. So to kind of leave you with a human face on this, it turned out even before the data were publicly available, it was clear the drug was working because the VHL patients were posting on social media how they were responding to the drug, as patients are allowed to do. So here's a patient saying, I never thought I'd see this day. And I'll remind you, this disease is transmitted in a seemingly autosomal dominant fashion. These people have seen this disease ravage their family generation after generation after generation, in some cases going back to the 16th and 17th century. So they just assume this is going to be their fate. So here's a patient saying, I never thought I'd see this day, and they're describing tumors getting smaller, tumors being stable, or in some cases disappearing entirely. And because everyone likes a video, it was also sent to a vlog, and I am allowed to show this patient's face. And so if we could have the audio, let's see if we can get this to work.
Hey everybody, it's Justin. I just wanted to give you a quick update. I am in a gondola right now in Taiwan. Over there is Taipei 101. The gondola is actually right by the Taipei Zoo. But I just wanted to give you a quick update and say I'm doing well and enjoying my trip. If it wasn't for the PT2977 drug trial, I would have never been able to come out here and do what I'm doing right now. So I just want to thank Peloton, and I hope Merck will fast track this drug for a VHL treatment. So if you guys are listening, hopefully you guys will put it on the market to help VHL. But yeah, keep watching these videos. I'll be making more, and I'll get better at it, and I have to get the angles right because I kind of look fat, you know?
Yeah. So I like that because that tells me this person's back to their pre-morbid state. You know, that should be your biggest concern when you're in your 30s or 40s is whether you look fat on your vlog and not what your next MRI is going to look like. And so I'm pleased to tell you that just based on phase 2 data in those 61 patients and the dramatic decrease in surgery, the FDA did take the extraordinary step of approving this drug for the treatment of VHL associated neoplasms. So in closing, I showed you this earlier. So for the young people, and I'm increasingly, that's most people relative to me now, but for the young people, let me just leave you with one thought. I've yet to meet a successful person who at some point or another didn't meet someone who didn't believe in them, didn't think they could succeed, didn't encourage them. And that certainly was the case for me, as I mentioned, when I was working and struggling in my first laboratory. So there are two things you could do at that point. You can either wallow in self-pity and believe this person who tells you you can't do this, or you can prove them conspicuously wrong. So I would argue the latter is much more fun.
Kaelin, born in New York, in the United States, is affiliated with Dana-Farber Cancer Institute in Boston, Harvard Medical School in Boston, and Howard Hughes Medical Institute, Chevy Chase.
I was wondering what my professor would have been thinking about that. And finally, if you happen to be in Stockholm, you do make a donation or two to the Nobel Museum. Now, for personal reasons, I was late to the ceremony where you make your donations, and so I could see that one of my fellow laureates had given an autoradiogram that I thought was great, but I don't think the average 12-year-old would know what the heck they were looking at. One of my laureates put in a sort of a treatise from the 1950s that was in a physiology journal about adaptation to life at high altitude. Again, I thought it was great, but I thought maybe something for a 12-year-old. So fortunately, I gave two things that actually prompted the curator to cry, which I thought was a good sign. So this is the toy microscope my parents gave me when I was 10 years old. And this is my medical equipment from when I was a medical house officer at Johns Hopkins. In fact, there's my badge. So thank you very much for your attention, and I think we also have some time for questions.
Thank you very much, Dr. Kaelin. If there's anybody in the audience who would like to ask Dr. Kaelin a question, please approach the microphone. I'll kick things off just by asking you, Bill, is, you led off with two papers that, yes, they were in mice, but they were in diabetic mice, and they were with HIF1 alpha.
Yeah.
To your knowledge, did they find a druggable pocket in HIF1 alpha that you can design drugs in this fashion for diabetic wounds?
Yeah, great question. I neglected to point out that they showed one other thing that I think would be of interest to this group, which is they showed that hyperglycemia per se lowers HIF level. So it's not just that more HIF is good, it's you could make, again, this is a correlation and plausibility argument, that the lowering of HIF by high glucose would negatively affect wound healing. So I think there are a number of arrows pointing towards maybe we want to think about HIF. Now you make the point about it's really in their models HIF1, but that's okay because, and again I apologize that I was going very fast, the HIF stabilizers, these prolyl hydroxylase inhibitors, they don't really discriminate between HIF1 and HIF2. So they would stabilize both. And in one of the papers, they were using a very early crude tool compound that does stabilize both HIF1 and HIF2. Now, if we really want to get into the weeds, we can get into some more HIFology, and we could talk further about how you could ramp up or down a little bit more HIF1 relative to HIF2. But again, I'm a lumper rather than a splitter. So I would say these now, in some cases, clinically approved HIF stabilizers, in my opinion, would be worth testing for diabetic wound healing and maybe other complications of diabetes.
Well, on behalf of the Wound Healing Foundation, I wanted to give this award honoring Dr. Kaelin for his time giving us this talk as the 12th annual William T.K. Hunt Lecture.